welcome to another episode of When Life Feels Messy.
Hi,
I'm one of your wonderful hosts, Ashley Barrera.
and I am your other wonderful host, Erin Raspberry.
And today is a very special episode.
Yes,
OMG.
we love a good guest.
Yes, we have a very special guest, Ramiro Saavedra. He's the adjunct faculty at our Department of Nutrition and Food Sciences here at the Houston campus.
Yes, but I think he does teach on all three. I think he's physically housed on the Houston one.
Okay. Yes. Well, it's extra special because this is our first episode of a series we're going to do with him.
Yes, a 3-part series.
Yes.
Okay, so in our first episode here, Ramiro does a brief introduction of himself, his experience. He is a registered dietitian, and so he does give like a good little synopsis of his work. He does a lot of different things. He works at a lot of different places. He is juggling many things, which is so awesome that he was able to come and join us.
Yes.
But in this first episode, he gives us a lot of good foundational information on eating disorders, disordered eating, with the difference between the two. We learned a lot of facts. There were a lot of myth busting about things that we had no idea about. It was a great and wild episode and conversation. And now I'm like, what else will we be learning in the next two? Because there was so much already in that one.
I know. It was a great foundational setting the scene kind of for the next two conversations.
Yes, 1,000%. So we hope that you enjoy this episode. Again, this is the first of 3. Next episode, we'll be getting in a little bit more in the specifics around eating disorders and what that looks like, and also treatment around it. And then the third episode, which will be in November, is where we will be asking you all for questions for Ramiro to be answering. So stay tuned for that. We will be sending stuff out. And yeah, without further ado, we hope you enjoy this episode.
Hello and welcome. Thank you so much for being here. Can you give us a little bit about your background?
Yes, so my name is Ramiro. I am a registered dietitian. I'm also faculty here at Texas Women's University, and I teach a course on eating disorders here in the university at the graduate level for our master's and PhD students. And then I also work with our dietetic internship program here at the Houston campus. Outside of that, I work for Houston Methodist at the Center for Weight Loss and Bariatric Surgery. So we do a little bit with some of what we're going to be talking about through this podcast series. And then professionally, by background, I am a registered dietitian. I have degrees in nutrition. I also have additional training in behavior science. And early on in my career, I completed a training with Baylor College of Medicine on adolescent health, which is where I received a lot of the specific training that I have with eating disorders.
Nice. That's a lot of experience, it sounds like. So thank you so much for being here. We're excited to start off the series and get into all things eating disorders.
Yes. Okay, so we're going to start this. We're going to be asking Ramiro lots of questions, and he is going to share so much knowledge and insight. But we can start off with something a little bit easier to get us rolling here, which is, what are eating disorders? And can you kind of give us more information of how that looks?
Yes. And so eating disorders are psychiatric disorders. They are defined in the Diagnostic and Statistical Manual. Then they have specific criteria, right? And so when we think of eating disorders, they have to have they have to meet specific criteria in order for someone to be diagnosed with it. And only someone that treats mental health disorders can diagnose an eating disorder. And so a lot of people get into the checklist in their mind and they think that they have one. And one of the things that I always try to emphasize with people is that with eating disorders, it is what defines one as clinically applicable for a diagnosis is when the disorder itself becomes distressful to the individual, it becomes dysfunctional to everyday life, and despite the word, it's deviant, meaning that it's different than what everybody else does and what the norm of the population is. And so what do those look like? We have eating disorders that focus on restriction, right? We have eating disorders that focus on binging and purging behaviors along with restriction. And then we've got eating disorders that are very specific to a behavior. So restrictive of certain items. Some of them involve just binge eating in general. And then others involve body image and body image issues, as well as a couple of atypical ones like pica that involve the eating of nutritional or non-nutritional substances. So things that don't have any nutritional issue or any nutritional cause to have to ingest, but people are eating them anyway. And so there's different things that come with eating disorders. We know that there are biological factors and genetic factors to eating disorders, but we also know that a big piece of the development of eating disorders is psychological and sociological in nature. And so we look at, the data and we look at the research. That is what we look at whenever we're defining what an eating disorder is.
Oh my gosh. There's so many layers to that I did not even realize. Is that kind of like, I guess a little tangent, is that kind of like common in what you see of there is a lot of just like, I don't want to say myths about it, but kind of thoughts about it, and then it's actually really different than what people come in thinking?
Yes, there's a lot of people that think, well, because I eat this, I may have an eating disorder. And it's like, well, no, you don't necessarily have one. There could be some things that you do that might be habits that you're developing that are unhealthy, but that doesn't necessarily mean you have an eating disorder. And I think the other myth too is that I've got to be diagnosed to actually have one. You can definitely have one and be not diagnosed. In fact, that's one of the things we probably will talk about in future podcasts is the underdiagnosis of eating disorders because people are not willing to get screened because of the stigma, right?
Gotcha. Yeah, I mean, that makes a lot of sense. Okay. Okay. Next question for you is, how does disordered eating different from eating disorders?
So, disordered eating is anytime that we have some type of behavior surrounding food and beliefs about food that is not what everybody else has or everybody else thinks. And so those are unique to everybody, right? I'll give you an example. I have a thing where I don't like my food to touch, right? And I kind of, if I had a plate that compartmentalized it, like when when you were in grade school and everything was nice and separate, that to me is a form of like a weird little quirky thing that I do with my eating. Where it can become disordered is if a food or a food item or plate is presented to me and things are touching it and I refuse to eat it. That's where I think the differentiation is. Am I uncomfortable that the things touch? Probably. But does it mean it's going to stop me from eating and I'm going to ruminate about it for the rest of the day? That's a different story. And there's people that get caught up with health beliefs and being healthy and a specific idealization of a body type. Everyone has that. It's a normal piece of society that we have to engage with. Where it becomes clinical is when it becomes dysfunctional or when it becomes distressful to you. And then even more so, if we want to get into the nitty-gritty of it, if it meets any of the criteria for diagnosis that's set by the APA manual. And that's what would differentiate it. So I'd say some people in the population have some form of disordered eating. Is it a clinically diagnosable, disordered eating? Could be, right? But again, we would have to have a professional screen them, and them have to be able to be vulnerable about what's going on in their lives and discuss it. But yes, there's a clear difference between just having some form of disordered eating that's mild, that isn't going to affect your life too much, and then having a full-blown eating disorder that's diagnosable.
Yeah, that example was so wild to me. Like, I don't think I ever thought of it. I don't know why in my brain I was like, maybe it's like overstimulating to some aspects, and so it makes it hard to even like think about that. But my wife does that, and now I'm like, oh my gosh, disordered eating. That's a whole thing.
Yeah, she's got a little quirk.
I know.
Yes.
Yeah.
Earlier you mentioned that you have to like kind of base off what everyone else is doing or what everyone else is not doing. Does that also keep in mind like that person's like background or culture?
Yes. And so that's a really good question because there is no baseline of what normalcy looks like in eating disorders, especially when you look at the literature. We really can't establish a baseline. What we do have is data on the typical eating patterns of the U.S. population, so to speak, right? And that's what we base the normalcy of it or the baseline of it. Now, with cultural considerations, that brings up a really interesting idea and topic for this is because what we may consider an eating disorder or disordered eating in one culture may be completely normal in another. And I'll give you an example. For example, in a lot of cultures, when you're mourning the loss of someone, it's completely okay to feel apathy towards eating, not wanting to eat. It may go on for a long time because it's part of the mourning process, right? But if you look at it through a westernized lens, right, or a lens like an American type lens, we may say, oh, this may be an issue. This may be, an eating disorder, but it may not be, right? And then, 10, 15 years ago, I remember my textbooks that I used to teach for like my intro to psychology class used to say that eating disorders were a Western disorder, were a Western thing, and that Eastern cultures didn't, struggle with that. What we find is if we look at it through a different lens and we remove the Westernized view, we will find them in those cultures as well. They just look different, right? And we think about it, just as we're looking at and we're treating patients, it's important to assess that. What are the cultural beliefs that your culture has about food? And how does that play into your day-to-day life? And are you ruminating on things? Are there ideas that you have that are completely taking over your thoughts every day? And what are they? So it's a very great question to ask because cultural considerations with disordered eating are really important because we are living in a culture where there's people from different walks of life, different backgrounds. Some people born elsewhere but raised here. Other people came here when they were older. And so they brought some of those things along with them. And nothing is right or wrong. It's just being aware of the differences.
Yes, that was a good question.
That's what thanks. That's where we see. I see like the generational differences in the same like household when like a student is living with their grandparents and their parents, or maybe like a really older sibling, and they're trying to like implement what's important to them and maybe different from that older generation.
Oh yeah, absolutely. One thing we see a lot like with generations is that, traditionalist Gen Xers and baby boomers, when we look at the generations that are in the population now, they tend not to want to acknowledge the eating disorders, even if they're carrying out behaviors that could be detrimental to their children in promoting eating disorder or disordered eating behavior. They don't see it as that, right? I'll give you a really good example. Sometimes when we talk to patients about like, where did all this start for you? And it often starts with the eating habits that they learned from their mothers or fathers. And a really common one is, well, I ate a lot already throughout the day, so I'm just going to have a bowl of cereal for dinner, or I'm going to skip dinner and just have a piece of fruit and some water. And people then begin to think that this might be the normal. And it could be the normal for someone to just have 2 meals a day and maybe a snack. It really is individualized when it comes to diet. But when it gets added to this preoccupation of weight gain and body image and thoughts about how your body defines who you are as a person, that's when it could become a little bit more problematic.
I gotcha. Okay. That made me think of something. I don't know if it's applicable to this, but I guess maybe on the other side of that, I'm thinking of like, I grew up with the mindset of like, food is expensive, and so you have to eat like your whole plate kind of thing.
I was just thinking
Right? Like, so is that also something that y'all see? I don't know if it's accurate for this, but
Yes, we do see that. One of the things I teach in my course is when we talk about childhood eating behaviors. And we know from the research that our adult eating behaviors are developed during our adolescence when we're still children, right? And part of it is because during adolescence, you're developing identity and you're developing the idea of being independent, right? You get to pick what you're eating now. No one necessarily has to tell you what to eat. You're at school, right? And you're making your own choices about food. And even if you get sent to school with a lunch from your family, you're deciding what to eat in the box and what not to eat in the box, right? So you're already beginning to internalize what your friends are saying, what social media might be saying, on top of what your family has taught you, right? And so that's another thing that comes into play. When we look at how people were raised, we have a name for it, and we look at somebody's family of origin. And the family of origin kind of defines those things. Like for you, it was, well, food costs a lot of money, so you got to eat everything on your plate. For me, for example, I was a very picky eater as a child, and my mom would always be like, well, you're not leaving the chair until you finish everything on your plate. And so it was this idea of like, finish everything on your plate. Food is expensive, so, we've got to make do with what we have. You're only going to get dessert if you do this. And all these thoughts and all these behaviors and things begin early in childhood, and they can be carried on into adulthood. And one of the things with eating disorders is that when we begin to have an abnormal relationship with food is when we begin to see a lot of the issues that arise with that. And some of that relationship begins to form early on.
Oh gosh, it's so fascinating. I don't even think when you were talking about a kid that brings a lunch to school, right? And they're getting to choose what they eat, but they're also hearing like what their peers, right? Like might say, or if they make comments about like, what did you bring? Like, why is that your lunch kind of thing? Or like even societal like expectations, but then also like your parents, what they're saying. Like that is so many layers for someone. I don't even think I thought about it in that depth. Gosh, it starts so young, like to have all these elements present. But I think we kind of touched on this, but I wanted to come back to it. Are there any kind of like big myths about eating disorders?
Yes, I think the biggest myth that's been pervasive for a long time, meaning decades, is that it is a female-only disease. That is a big myth, and that is not true. We definitely see eating disorders in males, but in the past, what the research had done, and this is true of any research that looks into gender and gender identity and things like that, is depending on what lens you're looking at, it'll determine what you're going to find. And we often looked at men and people that identify as men through a female lens and expecting to see the same behaviors that we see in women and men, and we don't. And we know that they are just as common as they were. We used to think and say like, yes, they exist in men, but they're underreported, and that's still true. They are underreported, but I think they exist in the same prevalence. They just look different with men. Things that's highlighting that is the increased pressure on men to look a certain way now than say 10 years ago because of social media. So one big myth is that like, oh, well, this is only a white female disease. Not true. It is a disease that can affect anyone of any background, anyone of any sex or gender or gender identity as well. And we can talk about that in a future podcast. And I think we will talk about it a little bit later about what some populations may face and where they fall through the cracks, right? But another myth is that this is something that only happens in childhood or adolescence. Also not true. I've treated patients who were 75 years old and they'd been struggling with their eating disorders since they were 19 or 20. So the idea that the eating disorder only happens and it resolves itself in adolescence or early adulthood, also not true. Some people can struggle with this for a lifetime. And then the other thing I'd say is that it was also believed to be an eating disorder for the wealthy. And not true either. We can see disordered eating in all levels of socioeconomic status and across all cultures.
I do appreciate though, like you highlighting and validating the aspect of for men, it is very common as well. And also the social media piece of that. I mean, especially with all the things out there, there's so much criticism and just expectations on bodies in general, but I'm seeing that more and more of men kind of talking about the expectation and the pressure. So,
And you hinted at it a little bit earlier with like the different generations, but how also does it show up across other demographics?
So when we look at other demographics, so we talked about age, we talked about gender. When we look at other demographics, so for example, we take the LGBT community, right? And we look at sexuality. What we find is that the LGBT community is at a higher risk than the heterosexual community. Why? Because there may be different standards of body image. There may be different standards. Interestingly enough, it's more so LGBT men than LGBT women because there are different standards of what that group wants or expects as the ideal body, right? Or the ideal look, right? And then when we look at other demographics, so for example, we look at education status. What we know is that it makes no difference. We can find disordered eating with someone that has PhDs and master's degrees, just like we find someone that doesn't have a high school education. What we're finding is that the risk factors that are psychological and biological or genetic are stronger, right? In some cases. But society or the environment still plays a big role in whether that develops or not.
So you mentioned it's not like a specific demographic, and you mentioned it's more like biological and genetics, but nurture, like the environment still plays a big role.
Absolutely. So one thing we've learned that we didn't know, say 20 years ago, is that there are genetic factors associated with it. So we know that when we look at genes and genes that code for thinness, so to speak, we can see that in family studies with twins, that monozygotic twins are more likely to share the same body type as well as the same appetite and release of neurotransmitters and hormones. And we look at the opposite of that. We're getting a lot of research right now on genetics and obesity, right? And we're also seeing that being part of it. But what is really interesting, and again, not new, but it's interesting to look at it in this space, is the idea of epigenetics, right? And how, yes, the argument used to be, is it nature? Is it nurture? The conversation now is, it is both, and they push against each other. So you can have genetic predispositions to an eating disorder, but if you're in an environment where it does not allow that to form and completely come through, then you may not develop it, right? It could be, the environment could be both a factor that contributes to it or a factor that protects you from it. And so that's one of those things that, and it plays a small role, I would say, in the broader things, because the psychological processes are one of the bigger risk factors that leads someone to develop it. And then, of course, the environment, the social, cultural, the pieces of where you live, the groups that you're part of that allow an eating disorder to develop or not develop.
It's so fascinating to me about because you hear so much, right, about the nature versus nurture concept, but even to think about like the nurture part of it can be like a protective almost like element there.
Yeah, in the twin studies that we look at, you'll see, like, for example, twins, same, monozygotic, identical twins that were raised in different environments. Depending on the environment, they may keep a thin figure for the majority of their life. But if one of them was raised in an environment that was slightly different, they may actually have a higher BMI or higher weight than the other twin. And so it's interesting to look at that, as well as when we look at individuals with genetic traits for obesity, right? And we look at one developed in an environment that was, very much normal, and I'll put that in quotes, and then someone else developed in what the research or the literature calls an obesogenic environment, right? And we're not trying to put stigma or blame on the environment or the word, but that's just what the research calls it. And what is that? It could be an environment where there was food insecurity. So the only thing they could eat was fast food, right? It could be an environment where someone didn't have the time to cook for them. So everything they ate was out of a box, was frozen. There's nothing wrong with that food. It's just, it becomes your sole source of nutrition. And over time, if they were around other people that overate, we know that we can override our hunger and satiety cues. The feedback loop that exists between the vagus nerve and your neurotransmitters, as well as your hypothalamus, that feedback loop for satiety and hunger can be overridden over time.
Whoa, that is wild. I didn't know that. But it makes a lot of sense. And when you mention over time, is that like in the moment of eating or like throughout the lifetime?
Through the lifetime. So in the moment of eating, you'll do it once, no big deal. Your body still feels like, okay, well, we know when to stop. But like, take somebody with binge eating disorder. Over time, they develop that because they've overwritten that cue over and over and over again. And now it's just normal to them. They're desensitized to it. The same way that someone with anorexia over time is desensitized to the sensation of hunger. Like, they no longer feel it.
I didn't even think about like that correlation or how that shows up, but yeah, wow.
In the area of demographics still, how do eating disorders show up in communities that are often left out of the conversation?
A lot of times eating disorders show up as a secondary to something else,
Okay.
right? And so when we look at communities that are left out, both from access to treatment, that are left out of the conversation, out of the research, a lot of it is communities of color, because I think the myths we talked about earlier, people may believe, well, that doesn't exist there, so why go looking for it there? Communities that don't have access to healthcare, because how can you get screened if you don't have access to even go see someone about it? Another piece would be, the LGBT community, because a lot of times, individuals that belong to that community, they are already left out from other things, right? If you think about somebody, you come out to your family is not supportive. They tell you to leave. You're staying on your friends' couches. You end up in shelters, and you develop depression, you develop PTSD. There's trauma involved with that. And then that leads to restrictive behaviors about eating, rumination about when's my next meal going to come. And then that leads to a bunch of other things, right? And so when we look at that, that's how they show up. And those are the communities that are most at risk, as well as when we look at overall communities and we look at, people that may be in a relationship that is not healthy for them. That's another piece that we look at when we, um, look at, and there's not a lot of research on this, on whether it hits people that are in relationships versus people that are single. We see the main risk factor is not so much the relationship, but the quality of that relationship. In abusive and traumatic relationships, there's a higher risk for an eating disorder.
Wow. Intriguing. I know in my brain, thinking about that, it makes me think, and I would be curious of your thoughts on this, but I think when I've heard a lot about eating disorders, disordered eating, I always hear this element of it's about control, and I don't know your thoughts on that.
I would have to agree with that, just based on what I've seen. Because if you think about it, let's talk about an adolescent who has developed an eating disorder, and people tend to think of, or like when the parents bring the patient in, oh, we don't know where this came from. We don't know where this started. Um, and then when we start doing family therapy and interviews and things like that, we begin to see that, it kind of started during the divorce. Ah, and so when you're a child and you don't have control over the relationship that your parents are going through, and you don't have control over the things going on in school, and you don't have control over basically anything, what do you have control over? Yourself and what you can eat. And it becomes a fixation of, I feel a loss of control and I want to regain that control. And the way that I'm going to regaining is with myself, is I'm going to restrict, or I'm going to binge, or I'm going to overeat. There was this idea that when children do that it was done for attention. That is very much incorrect. We know that if they're doing it, sure, attention could be a piece of it, but there's a clinical reason why they're doing it, and we should pay attention to it and take it seriously. Give you another example. This was a very interesting patient that I had, probably one of the most interesting patients I had. She was diagnosed with binge eating disorder. Her binge eating disorder resulted from a traumatic, abusive relationship with her husband. He would stay out all day and all night, didn't work. She would come home from work and, prepare food. She didn't know whether or not he would be in the mood to eat the food or not. She also didn't know if he would be upset about the food. And mind you, he would choose what the food was. He would say, cook me this, but he would find anything in there to then be upset. Oh, you didn't do this right. This was too salty. And then what would happen, unfortunately, was the person was physically abused. As soon as he came home, he may have already been drunk or on some other substance. He would abuse her. And then as a result, she felt very much, nervous about it all. And so one of the things that was happening was, as he was coming home, she knew that this was coming. She knew he was going to come home. She knew the abuse was going to happen. And what ended up happening is she would binge eat out of anxiety. about what's about to happen because it was going to happen. And so she would binge eat. And then what she would do after the abuse happened, she would restrict for days because she would feel guilty about having so much food in one sitting. But being Hispanic, one of the things that is hard to do is when you go to people's houses, it's hard to refuse food because it's seen as like a rude thing or, you should accept what your host is offering. So what she did is she created the lie that she had diabetes. And so she would tell people, I have diabetes, I can't eat that. But really she was restricting, right? So that's another example of how trauma can feed an eating disorder and how the need for control, because she had no control over the fact that the spouse was going to be abusive. She had no control over how he would react over the meal that she had prepared. What she did have control over is what she could eat and not eat and when she couldn't do it.
There's so many layers to that story and experience in itself. That is so interesting of her using or even like coming up with using diabetes as a way to even like continue doing what she's doing, but also keep the peace.
Yeah.
Almost.
Yeah. There's more to that story. That story is a very long story, but I just hit on the control piece of it.
Yes. Yeah. Oh, I can only imagine. Thank
you for sharing.
Yes. I guess kind of like on the vein of family stuff, we can kind of transition to that. And we kind of talked about it a little bit, but how do you see family systems influencing lots of different things like body image, food beliefs, self-worth, patterns, and beliefs about food, etc.?
Oh, family plays a big influence. They are the first to teach you about self-esteem. Your family is the first to encourage you or discourage you, right? And when we're growing up, we seek validation from our parents. If you have older siblings, you may seek validation from your siblings. And what we find in practice, especially when we look at, we do family interviews or we do family therapy, is that a lot of times, without meaning to do it, sometimes the parents or the siblings are the ones contributing to the body image issues. Or, for example, I had a client once that I worked with that her eating disorder kind of stemmed from the idea that her family was a very fit family. We're a fit family. We run marathons on Thanksgiving. We do this together. This is what we do together. And it wasn't a bad thing. People, want to do things together. Some families sing. Some families like to garden. Some families like to do crafts and things together. This family in particular liked to exercise together. And this was a belief of the parents, right? And they wanted their children to be healthy and, partake in exercise. Well, for this individual, it became very stressful and it was becoming more problematic than it was being helpful to focus so much on exercise and wanting to exercise and needing to do it and things like that. And so that particular person developed disordered eating and body dysmorphia and things like that as a result of that. But sometimes parents poke at their kids out of fun, to make fun of them. And it's just parents being parents. But there is a line that you can cross that parents sometimes don't realize they cross it. And then they have to backtrack and realize, hey, my actions for the last X number of years have actually contributed. And it's a hard thing for parents to realize and come to terms with in therapy because they have to then acknowledge that they've played a role in this, which is hard for them to acknowledge because then they start internalizing their own idea of, does this make me a bad parent? Am I a bad person because I did? And then they don't want to engage with that, right? But the beliefs that you're raised, like we talked about family of origin earlier, but also the comments that people make about your body, the things that they say about you, that over time can create a risk factor for eating disorders. I'll give you one example, and not necessarily an eating disorder one, but I've always marched to the beat of my own drum growing up. And I always did things that were not what everybody else was doing in my family. And I remember my mom always being like, well, your cousin is doing this and your other cousin is doing that. And I always got compared to people. And since I was a child, I would straight up tell her, don't compare me to people. I'm not them. I'm Ramiro. I am not this person. I am not that person. Don't compare me to what they're doing, right? Because I may not want to do it. And she'd be like, well, look, this person's doing this. And a lot of times it starts like that. Well, this person, look, they're taking care of themselves. And I think parents want the best for their kids, but they sometimes end up saying comments, creating behaviors, and getting their children to ruminate on things that are not appropriate for them to ruminate at that time. They're kids, right? They should focus on what feels right for them, learning about themselves, being happy, having a normal childhood. and you begin to stress kids out with that, that becomes then later a risk factor for an eating disorder. You can grow out of that, and a child can fight against that with surrounding themselves with people who don't believe that. But that's definitely a big risk factor. I've even heard patients say, well, like every day that I would wake up, like my mom would do an inspection on my body. Like they would pinch my love handles, or they would pinch my underarms and ask me why I wasn't toned. On the flip side, for boys, interesting enough, we can get, this is a whole another podcast, but when we look at masculinity in boys and how they develop things like that, a lot of that is internalizing what their fathers say and their idea of masculinity from their fathers. And so the idea of like, you're getting pudgy, you need to start working out. You're getting to the age where you need to actually start hitting the gym. You need to go with me next time. And the father's trying to do something positive, trying to teach their child to work out, be fit, things like that. But it's how they go about it, right? And how you have the conversation and what beliefs come out of that conversation. Are you associating positive or negative emotions or feelings to an activity, a behavior, or food? Or are we just doing it because the overall goal is health, right? And so there is a lot that parents can do when they have those conversations of setting the tone that this is to help you XYZ. If you fail at it, if you're not good at it, let's talk about something else. We're not going to hold you to the standard that we know is going to set you up for failure.
So it sounds like you're teaching parents how to have those conversations, like that language. It's like a new way to talk.
Right. And when we look at younger generations, they're a lot more sensitive to the how of the conversation, how the conversation is had. Where before, a traditionalist parent could be super direct with their boomer child and it was fine. We cannot do that with our millennials and our Gen Zs and our Gen Alphas. It takes a different type of conversation. We can get the same point across, right? But we can't do it in the way that we used to. And there's nothing wrong with that. Yeah. It's a generational difference and we have to adapt to it. And I think that's one thing that we try to bring to awareness for parents is, hey, maybe the way you're talking to your kid could make a difference in how you do this. Maybe the way that you're presenting food could make a difference. Right. And that's a big piece of our conversation, in family therapy and individual therapy.
Sounds like such impactful conversations, but also takes a lot of accountability on the parent's part. Yes. I can see where that gets a little icky and dicey for people that are not comfortable with that.
Yeah.
Also, kudos to you for setting boundaries with your mom from a young age.
I'm still setting that.
I feel that 100%. Work in progress always.
I think she's gotten the point though.
I think we also kind of talked about this, but in terms of what kind of messages from childhood tend to stay with people in adulthood, are there any big, I don't know, maybe thoughts or things that you see more and more that maybe people kind of commonly share?
Yes. One thing that if you send the message in childhood, it's pervasive in adulthood is that you're only going to be valued if you look a certain way. Ooh. That's a big one. And we can talk about that in terms of just not just your body. It could be the way you dress. It could be the way you do your hair. It could be all kinds of things. But a lot of times parents mean well when they try to teach their kids to look a certain way, dress respectably, and do this and that. But again, the takeaway may be different with the child, all right? And so things about, your body determines how people treat you. So you need to make sure you always look this way. Or ideas about, like we said, finish your food and always eat and don't throw away food. That's a big one for me now, that I will take leftovers home, knowing full well I'm not going to eat the leftovers, but I take them home because as a kid, we didn't have a lot of money. Right. And so it's bad to waste food.
Yeah. I'm such a culprit of that too.
But the reality is, I know I'm not going to eat it. And there's nothing wrong with leaving it in the right. There's a little bit of guilt, knowing that the food's going to get thrown away. But at the same time, I shouldn't feel an obligation to take it home, especially if I know I'm not going to eat it and it's just going to sit there in the fridge. Or the other thing too is if you're living with a partner, right, you may not eat the food, but your partner may eat the food because maybe they grew up in an environment or in a household where food was scarce. So if there was something in the fridge, let's go for it. And I've heard lots of stories about that of where does your binge eating come from? Oh, well, I tend to kind of binge on whatever's left over in the fridge, or I tend to binge on the things that I couldn't eat as a child that now I'm allowed to eat because I'm an adult. Right. Things like that.
Yes. One that I heard is that if you eat really fast, then you'll gain weight. And
Yeah.
so I was like told, slow down,
Yeah.
take your time.
We want to promote, chewing and digesting your food because digestion begins in the mouth, both with mechanical chewing, but also when the enzymatic processes in saliva. So saliva has there's salivary amylase and salivary lipase that help begin digest food at the molecular level in your mouth. So as that bolus of food goes down your esophagus into the stomach, then the gastric juices do their part. So there's layers to digestion. Does that mean if I take a big chunk of food and I eat it quickly, that it's going to cause weight gain or weight loss? No. At the end of the day, it's just about, how much you ate, really.
Yeah.
But again, you could see that in a lot of people's beliefs. And some people were told that, as a fear of like, if you do this, then you're going to gain weight. And then some people were told that because it was like, well, it's just plain manners. Like only slobby people eat fast and da 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 da. You have to be poised and you have to eat a certain way. And, some people do grow up with very strict table manners. And that can be another thing that leads to, because one thing we see in some eating disorders are rituals around eating. I've got to do XYZ first. This has to match. I've got to do this, and then I can eat the food. And then sometimes if none of that's in order, they won't eat.
If I don't have if I'm sitting at a table with people and not everyone has their food or not everyone's ready to go, I cannot start. I guess it's a quirk, but I also grew up very religious and you had to pray before you could eat.
Right.
And so I still feel that even if I don't pray anymore, but it's so interesting of even how stuff like that kind of shows up. But something that you were talking about that made me think of is I also heard a lot growing up of if you leave food left over, how many people
The starving
oversee
children.
the starving
in another
children. You're
country. Yeah.
so wasteful. They would be so appreciative of these small bites. And that still sticks with me to this day when I'm
Yeah.
I have 2 bites left. I'm not going to force myself, but I feel like I should.
Yeah, and that's so common because when you think about generational differences, traditionalists and baby boomers may have grown up in an era where food scarcity was common for the whole population, right? Think about it. They were coming out of the Great Depression. The traditionalists came out of World War II, the Korean War. All these conflicts that ended up with food shortages and, people being much more mindful of that, that can then lead to them passing that on to their kids. When in reality, what we should do is encourage people or children to follow their hunger cues. Because one thing we do know is that children eat a lot more intuitively than adults, right? They will eat when they're full, when they're hungry, and they will stop when they're full. And that may not meet our definition of eating. It is normal, just like a baby. It is normal for a baby to feed multiple times a night, 12 to 15 times a day, right? When they're young. As we grow, right, the meal patterns that we see are very much self-imposed. There's no research out there that says that 3 meals a day is the gold standard and that's what your body needs. You can do 6 meals if you want. You can do 7, if they're smaller meals, or you can just do 2, or you can do a big one and a snack. The point is to get your nutrients and your calories in, and not necessarily about how many meals you have. But we get stuck with this idea, if you didn't eat breakfast or lunch, or if you're doing this,
Right.
then it's bad, right? Or, in your examples, well, I can't, I have to eat everything on the plate. But do you? You don't really have to, right? But that's an idea that we grew up with and it stays pervasive, right? Because we think that there's some scarcity, but when in reality, we have a lot more food nowadays available to us than we did before. There's convenience foods. There's a lot of shelf-stable foods that we have. So that idea is not necessarily real anymore. But this is separate from food insecurity, right? But when we look at that, that's a big piece of why some people continue to, to have some of these beliefs that then can spiral out of control. Perfectly normal to have them. Again, it's when they begin to take over your life that then that becomes where we get more concerned about whether or not it's an eating disorder. But that is very common.
Yes.
On that note, how do our patterns with food reflect those deeper emotional or psychological needs?
A lot of times we can see people's relationship with food is also a reflection of their relationship with themselves, right? When we see patients that restrict, right, a lot of times it comes as a also a broader reflection of I'm undeserving of something, right?
Mm-hmm.
And you tie that to your self-worth, because eventually when you have an eating disorder like anorexia or something that just gets really out of control, a lot of that is tied to a person's self-worth. And so when we think about the deeper connections there, people begin to place emotions on food. They begin to place value of self-worth on whether or not they eat a certain way or a certain type of food. On top of that, a lot of people begin to develop this unhealthy relationship with food that is centered on the idea that if you eat a certain way, you're a better person for it. If you don't eat this way, then there's something wrong with you, or you're
Right.
bad, or this. We see this a lot in social media, especially with
Mm-hmm.
influencers that are trying to do like fitness or health influencing.
Yes.
Without knowing it, they are sharing information, they are saying things that could be hurtful to the audience, right? Because they're giving this idea that if you don't eat exactly like me, then you're not a healthy person. Health looks different for different people, and you don't know what other conditions, health conditions a person has that
Yes.
they could be eating differently for.
Yes.
One thing I've heard is that like will be a healthier person or a better person because I'm displaying discipline in my eating and my eating habits or what.
Yeah, and I have a lot of problems with
Yeah,
when we
and
say those
discipline
things.
in life is very valuable.
Available, yes.
Mm.
And that's, I think that's again goes back to the person seeking control, right? Because
Oh,
there's this
Yes.
idea that discipline and control make you a better person. Discipline and control are what keeps you from being erratic and emotional. Because again, they're not just talking about discipline with the food. They're talking about discipline when you eat, discipline with your emotions, work ethic as far as discipline goes. They're covering the whole spectrum of that. Is there anything wrong with that? No, it's great to have a good work ethic and have a routine that you can sustain for exercising, a diet that works well for you. But they're almost putting it in such a rigid box that so many people cannot fit into. And what everyone doesn't realize is that some of these influencers don't have a day job. Their job is to be an influencer. They receive their income from the sponsorships that they have, from the views that they get on their YouTube videos that then are monetized by YouTube. And so they're paying their rent and they're doing all that with their money that they get for the influencing. The thing that they don't tell people is that. And so everybody thinks like, wow, this person wakes up at 5 in the morning, they go run, then they go to the gym, then they eat healthy, and then they go to their job and do all kinds of things. They don't. They go back home and they do whatever it is they do. They create more content. They have the ability to exercise multiple times a day, prepare their foods at home, do all these things where the average person may not have that. They may depend on a meal or two to be a fast food or a convenience meal just because of, life, right? If you have kids, that adds an extra layer of, lack of time. But yet there's this ideal, this pedestal that these people have put on that this is the only way to do it. And if you're not, then you're undisciplined. And, if you're undisciplined and there's something wrong with you, this is super pervasive in male influencers. And the younger male generation is extremely sensitive to this, is that I need to have control of this. I need to have control of that. Are there going to be situations where you don't have control? Yes, always, because you cannot control. If you spend your life trying to control everything, it's going to be a very miserable life. Yeah, because you're going to have to accept that there are things that you can't control and there are situations that you can't control. And that is one piece that people struggle with kind of, overcoming, is the idea of perfectionism. Because when we look at psychological risk factors, perfectionism, cognitive inflexibility are two big ones that lead to eating disorders. So, and also impulsivity, right? And also the need to control that impulsivity is another one. So when we look at those psychological risk factors, that cognitive inflexibility, I must do it this way or I can't do it, right? Or the other idea of perfectionism, right? Setting a standard that is unattainable and working to reach that, knowing it's unattainable,
Right.
is you're going nowhere. You're chasing yourself in circles, right? Versus setting something that is more realistic to you.
Right. Right. And on that note, how can we like have that new language of helping people feel more in control or just like talk about their feelings when it comes to food? versus avoiding it?
Yeah, I think that it is really important and this is something that we can start on a day-to-day basis, right? One thing I always try to tell my students is, being a dietitian, we're not the food police. We're not here to judge what people are eating. We're here to evaluate it, and then give them an assessment of what we think needs to be added or subtracted, if they have health goals they're trying to reach, right? And so how we talk about it is really important. So I think one of the takeaways, both for our audience and something that I always tell my students is think about the way that you would feel if someone made a comment about that for you. And maybe you'd say, oh, I wouldn't care, right? But then also think about that not everyone is you, and so while you're okay with somebody making a comment about what you're eating or your body or whatnot, somebody else may not be. I think that the big takeaway for people and clinicians too, because doctors, nurses, everybody's kind of guilty of it at some point, is pushing our beliefs on other people and giving unsolicited advice. And that's a big one that I think we can learn not to do, because a lot of it, we don't know how people are going to internalize it, right? So I'd say, when we're having conversations about food, unless somebody asks you for what you think, don't share it,
Right. Yeah.
do what you do, but don't feel the need to compulsively share what you think if you're not being asked for that, right? Because you could inadvertently end up giving information or planting a belief in someone's mind that something they're doing or feeling is incorrect. And I think the more we normalize talking about emotions, I think the easier it will be for people to not be afraid to talk about it and how we feel about weight gain, how we feel about a specific food, because there will never be a time when we completely eliminate from the population this idea of food being used as a reward. It's always going to be there.
Yeah.
Even if we don't do it like we were with kids, like you only get dessert if you finish your plate, or you only get dessert if you were good, throughout the day, or you got good grades. As adults, we may use other forms of rewards, right? And that will never go away. And it's good to reward yourself when you do something good, you accomplish a goal, right? It's this idea of like, well, I didn't do it, so I'm not deserving of it. And then internalizing that to your self-worth and who you are as a person. That's where the issues can become.
There's a lot of information, but so valuable, valuable to see that connectedness of emotions, those beliefs, and just those behavioral patterns.
Yeah. And one thing there's an assignment I give my students in the eating disorder class is like a food and mood tracker, because being aware of what emotional state you were in when you ate the meal is really important. And a lot of them will tell me like, why do we do this? I don't need to know that. Yes, you don't, but this is an exercise that you may give your patient. So you need to be able to explain to your patient why this matters. And so in the little tracker the little assignment I give them, it's like, well, what time of the day was it? What did you eat? If you can give me specific measurements, even better. Where were you? What was the setting? Who was around you? Did you eat with somebody? Right? And I want them to see how and then what did you feel before you ate? What did you feel after you ate? Right? And then all of that, I want them to get an understanding and to see, hey, when I eat with people, I tend to eat more. When I'm stressed out, I tend to eat more. When I'm worried, I tend to eat less, right? When I'm in a situation where I'm pressed for time, I tend to eat less and I'm less conscious of my food choices. And so we I always, what's your environment when you were eating? And so they also find like if I was watching TV or scrolling on my phone or watching something on my iPad, I tend to eat more because I'm not aware of it. I'm just kind of putting food in my mouth. And before I know it, I ate the whole bag of chips, right? And so aware of that and just, doing that little exercise is really helpful.
I mean, obviously as therapists, a mood tracker is something that even we kind of have in mind, but the idea of the correlation between what you're putting in your body and eating with how that correlates with what's going on for you mentally, emotionally is really fascinating. And it makes me want to do it and kind of see.
Yeah, it's an interesting activity because then I have them do that as a homework assignment and just submit it. And then I just give them credit for it. Later on, when we talk about family and things like that and how that ties into your eating behaviors, I have them go back to the assignment and reflect on it and write me a little reflection. And some of them have said, like, I didn't notice that I tend to eat higher volumes of food when I go over to my parents' house because my mom will cook for me. And I didn't realize that. And so, like, that day, I ate a lot. And when I looked back as to why, well, it was because I ate this, or it was a weekend and I had parties all weekend. Like, it was a birthday and then it was a graduation. And there was a lot. So I want them to also see how social events can also be something that changes your eating pattern for that day.
It literally makes me think of like when I go to my grandma's, like I'll like make a plate, and sometimes I try to be really conscientious of like whatever like my capacity for hunger is, but every time, like as soon as my plate starts getting empty, she's like, "Do you want more food?" And is like, already has a spoonful of it and is like trying to force it on my plate, and I'm having to like, "No, I'm good." And she's like, "No, you need more." And I'm like, then it's like the concept of like, well, I don't want to be rude. Like I want to be like, "No, grandma, please put the spoon down."
Yeah.
But I'm like not anymore. Like I'm not hungry anymore. So it's like such a balance, but that makes sense, right? Of like, even like what your pressures or expectations of what the people you're around, kind of like what you said, like even culturally, right? It can be offensive if you are not even open or receptive to the fact that someone is offering you food when you come. So interesting. So many layers. I feel like I say that so much this episode, but so many layers to this.
Yeah.
Well, this is just laying the foundation for our other two conversations to come.
Oh my gosh, I'm so excited. I guess like we're kind of getting to the end here. And so last thing maybe we can kind of wrap up with is, and you kind of talked about it earlier of like barriers, right? And I know we kind of said like access to healthcare, right? And itself is a huge barrier. So first part of that, are there any other that we haven't shared that we can kind of talk about so far?
Yes. So one big barrier is lack of treatment facilities and lack of professionals who have experience dealing with this. So you both are therapists and I'm a dietitian, but I don't know that every single therapist and every single dietitian gets training in eating disorders in their school or in their internship or in their experience when they're doing clinical hours. And so we have a lot of medical professionals and allied health professionals who don't have the training. And so they want to help, but they can't because they feel like it's out of their scope. And I see that a lot with dietitians in clinical practice is they start to freak out and like, well, I don't want to treat this patient. There's a binge eating diagnosis on the referral. I don't feel comfortable with it. I'm like, well, can you treat the diabetes then? And then just let them know that we'll refer them out. So that's one thing is we lack a lot of healthcare professionals who eating disorders because there's not a lot of training in eating disorders in a lot of programs. So if you think about your program, did they offer an elective for eating disorders?
No.
Right? Then it's so specialized, such a specialized area of treatment. We offer electives here at TWU, to go if you want to go and get that kind of experience, but we're fortunate to have a class on it too. Yeah. Not a lot of dietetics programs have classes on eating disorders. Why? Because where are you going to find the faculty to teach it? In fact, part of the reason why I teach this course is because no one in the Denton campus actually has worked, to my knowledge, has worked with eating disorders. And so when we look at that, it's not uncommon. Nothing to my fellow faculty. It's such a specialized field. To find a job in it is really difficult. Some people do research on it, but research is one thing, clinical practice is another, right? So that's one barrier, is healthcare providers not having training in eating disorders. Two, depending on where you live, you can have a plethora of resources. So we live in Houston. We have tons of resources here and facilities that treat eating disorders. They specialize only in that. But suppose you live in more of a rural area. You may not have that access, or you may depend on virtual care for that access, right? And so that's another piece is depending on where you live, you may not have access to specialized care. Do you have access to therapists? Sure. Do you have access to dietitians? Sure. But are those dietitians trained specifically to deal with eating disorders? And we find that, that's another barrier. Two, we talked about having just regular access to healthcare. Suppose you do have access to insurance or something, then you got to deal with the insurance company because a lot of times they won't pay for eating disorder treatment. They won't cover medical nutrition therapy, or they won't cover a hospital stay for anorexia or bulimia. So doctors have to find a way around that. And let's say you're a patient that presents in the ER, with classic symptoms of severe anorexia, uncontrolled anorexia nervosa. They cannot admit you with a diagnosis of anorexia nervosa. However, they can admit you with a diagnosis of malnutrition. So, but what doctor knows that? Because they don't learn that in medical school, right? And then if you don't have an internist that has worked with that and refeeding and things like that, they will have no idea how to work around that, right? And then the only way to get around that is for them to call the insurance, do a peer-to-peer review for that person to get, admitted. And so there's also insurance barriers because very few insurance cover treatment for eating disorders, whether inpatient or outpatient. And then there's limits to how much they will cover, as if somebody determined that 10 sessions was enough to cure you. And it's not, especially when we know that these are lifelong illnesses.
I'm so intrigued, but one, I didn't realize of insurance being, I know insurance already has its things, but specifically around eating disorders, that in my brain just feels like it makes no sense given the severity that can occur with eating disorders.
They'll cover like the psychological therapy for it if you have psychological benefits or mental health benefits. But then when a doctor is trying to treat it, they may not get reimbursement if that's the only diagnosis. They may have to add low BMI. They may have to add a malnutrition diagnosis when they're submitting claims. And then for dietitian services, very few things are covered, but definitely not eating disorders. So a lot of times when you have an eating disorder and you need to see a dietitian to begin, your rehabilitation, a lot of times it's out of pocket. And same thing with a lot of these treatment facilities. There's some great treatment facilities across the United States, including here in Houston. But if you don't have insurance or your insurance doesn't cover it, all of that is out of pocket and it is very expensive.
Yeah. I could see where that would be a big barrier too. Like, cause then if it's like very small percentage of people with insurance that actively allow coverage for anything related to that, I could see that being something where people get so frustrated with it and just for mine, I'll just figure it out or I'll just keep doing, right? Like whatever it is that's going on. Like it makes me sad in the sense of how many people potentially have tried or are wanting to get help for it, but don't have the means and are reaching out, but resources that should be helping them are becoming more of a barrier for them.
Right. Or even sometimes I've heard from patients say, oh, but I've seen a therapist or I've seen a dietitian. And then when they talk to me about what happened in the session, it's like, well, they didn't really address it. Or why was the dietitian recommending this? I can tell because I'm trained and I have experience. I'm like, the dietitian should not have been doing that. Like they should have done X, Y, Z, right? But they were getting the help that they could with what they had available. Right. Yeah. And that's another thing is having to work with patients in times so they're seeing you as a dietitian or as a therapist and you've got the experience, but the other people in the healthcare team don't because it's fragmented, right? They're seeing a doctor in private practice for the medical piece. They're seeing a therapist in private practice or a joint practice for the therapy piece. And then they're seeing a dietitian on, Noom or one of these, virtual sites. And again, goes back to the lack of training overall in all of those fields, right? And we, even look at pharmacology, right? There are medications that we would stay away from when someone has an eating disorder, and there are medications we would switch someone to if they had an eating disorder. But again, the lack of training and knowledge about it is a big piece that's missing in the treatment.
No, I totally agree with that. I definitely didn't learn. I don't even think there was there definitely wasn't a class, but I don't even remember a lesson on eating disorders in general. And so it's I felt like I came out of it having just to find my own information, which is hard because then it's what do I trust here around this? So
that's not uncommon. So the only time, when you would think, so I did a whole behavior science degree. You would think, well, in the behavior science degree, you'd get some class. Nope. The only time we went over the just eating disorders at all was we had a class called just psychopathology. And all we did in that class was go over the DSM. Oh. That was the DSM class. That's all you did in that class was go over the DSM and get tested on the DSM. And that was the only time that we even covered an eating disorder was because we had to learn the criteria of diagnostics over it. But there wasn't a class that was taught by a therapist or someone that specialized in that. And again, reason being is it's hard to find faculty that have the experience. And yes, are there people out there with the experience? Sure. But do they want to teach? That's a different story.
Yeah. I guess last thing, and I think we've kind of touched on it on the other side of it, but if you were to kind of highlight, the the paradise of what it would look like if things were inclusive and equitable in the sense of treatment and being able to find and use the resources. Like, what would that look like from your perspective?
From my perspective, in an ideal world, right, everyone would have access to some kind of healthcare. So whether we're using the existing system right now where it's private, and you've got people that have insurance and don't, we should be able to have treatment facilities that are accessible. So maybe you don't have one in your town, but maybe the town over has one, right? I'd like to see comprehensive treatment facilities for this be much more common because that's where we see the most success, because there's communication between the care team. There's communication amongst the different professions. Everybody's trained. Some of them even require you to be certified in eating disorders to work there. But I would see it as places where you could go to receive treatment if you did have it. But even before that, I think in an ideal world, we would have a way that students can get, or anybody could get, free assessments about it. So maybe I'm not the person treating it, but I can administer an assessment and say, hey, I think you're at risk, or I think you need to see somebody, and then I can refer you. So it may be as easy as just having access to someone that can screen you and then refer you out. And then, of course, in the most ideal world, that you would have access to the treatment that you actually need for the length of time that you need the treatment, and treatment with an interprofessional team. Not just the psychiatrist or the psychologist or whatnot, but a dietitian, and everyone else that's involved in the treatment.
I would love a world like that too.
I know.
Especially with our students, that oftentimes don't have health insurance or have limitations to their insurance, like you mentioned. So is this a good time to wrap up? Yeah. Was there anything that we want to mention today, or?
But I do want to leave the audience with, but I do want to leave the audience with, something to think about. And I think the one thing that I could say that would summarize what we talked about today is that it's okay to not know, and it's okay to not be okay, right?
Yeah.
Because a lot of times when we begin treatment with eating disorder patients, one of the things that we have to break through, the barrier we have to break through, is the vulnerability for them to admit that they have a problem. And this is true of any mental health issue or any problem, right? Including things like diabetes and chronic illnesses. The patient has to be willing to admit, hey, I have a problem and I. So there's a takeaway from all the things we talked about. We talked about risk factors and, growing up and different things. But it's okay not to know. So if you didn't know that what you were doing could be, disordered eating, or maybe there's an issue with it, well, now you do, and that's okay. It's okay to learn it now. It's better that you learn some of it now or talk about it now. And it's okay not to be okay. Because when we admit that to ourselves, we're again engaging in vulnerability, and we're taking the first step towards a path of recovery. And that's where it kind of starts.
I love that.
What an uplifting end to the episode. Like you said, it was a lot of heavy content, but I know I learned so many different things that I had no idea, or even operated off of the myths, right? Of limited information that I hear and have heard growing up. So I appreciate all your insight. And I'm also looking forward to the other 2 episodes.
Yes, the other 2 episodes will go much more into detail on some of these things.
Yes.
Sounds wonderful. Thank you so much.
Yes, absolutely. Thank you for having me.
Yes, thank you,
Of course.
Ramiro. And we will see you again in October for our next episode.